Langerhans cell histocytosis, or histocytosis X, is a proliferative disorder of dendritic cells. Do you remember the main function of dendritic cells? They are professional androgen-presenting cells, and they induce the primary antibody response. Dendritic cells are called Langerhans cells when they are in the skin. If a patient has Langerhans cell histocytosis, their dendritic cells are immature and unable to properly stimulate T cells via androgen presentation. There are several different variations of this disease. In children, it commonly presents as diffuse eruptions on the skin, diabetes insipidus, and lytic bone lesions. One important thing to remember is that Langerhans cells are S100 and CD1A positive. An electron micrograph will reveal characteristic Burbeck granules that look like tennis rackets, as shown in this image. The chronic myeloproliferative disorders are a collection of different diseases that have two things in common. First, they are all chronic diseases. And second, they all involve excessive proliferation of cells in the myeloid lineage. There are four major diseases: polycythemia vera, essential thrombocytosis, myelofibrosis, and CML. By the way, CML is the only one of the four that features the Philadelphia chromosome. For polycythemia vera, what will the RBCs, WBCs, and platelets do? Increase, decrease, or remain the same? Well, polycythemia means increased hematocrit, and polycythemia vera is an increase in all of the myeloid cells. So we'll see an increase across the board in our RBCs, WBCs, and platelets. You can get primary or secondary polycythemia. Primary would be due to a somatic gene mutation, as we see here in polycythemia vera. And secondary is due to some other driving factor, like excess erythropoietin, or EPO. A pathognomonic symptom for polycythemia vera would be a person that presents with generalized pruritus, or itching, after a hot shower. What would we expect to see in essential thrombocytosis? Essential thrombocytosis has a selective increase in platelets, hence the name. However, the strange aspect of this disease is that even though your platelet count is high, you can present with both bleeding and clotting. The bleeding is because these platelets are abnormal, and although there are a lot of them, they do not function well enough to control bleeding many times. Next up is myelofibrosis. Myelofibrosis will show a decrease in the RBCs, and depending on the extent of the fibrotic involvement, you may or may not see a decrease in the WBCs and platelets. The pathognomonic finding here is the teardrop cell in your peripheral smear. You can remember this by thinking that the bone marrow is crying because it's fibrosed. You may also see immature cells of the myeloid line, as these cells are forced out of the bone marrow early. And last is chronic myelogenous leukemia. CML sees an increase in WBCs and platelets, with a decrease in RBCs. Be sure to remember the gene mutation we spoke of here. Interestingly, there is an important mutation to look out for in chronic myeloproliferative diseases, and that is the JAK2 mutation. The JAK2 signal transduction pathway controls the hematopoietic growth factor signaling, so it makes sense that messing with this pathway alters the number of different blood cells. JAK2 mutations are always present in polycythemia vera, and this is due to a somatic mutation, aka this is not a hereditary disorder. Because this mutation is a constant in this disease, the treatment for polycythemia vera is the JAK2 inhibitor, ruxolitinib. In about 1/3 to 1/2 of essential thrombocytosis and myelofibrosis patients, the JAK2 mutation is also found. By definition, polycythemia is an increase in the hematocrit. The hematocrit is dependent on both the plasma volume and the mass of the red blood cells. Altering either of these parameters can lead to polycythemia. Relative polycythemia occurs when the number of RBCs doesn't change, but the plasma volume holding them decreases. Can you think of an example when this would occur? Dehydration is one common cause, and burns are another. Here, we see a decrease in our plasma volume, with everything else remaining stable. Can you predict the labs in an appropriate absolute polycythemia? Well, AAP occurs in states where the body senses low oxygen levels and upregulates the expression of erythropoietin, leading to an increase in the red blood cell counts. Examples of this would include high altitude, where oxygen levels are low, congestive heart failure, and lung disease. So here we will see a decrease in the O2 sats and an increase in the EPO levels. This is followed by an increase in the RBCs as the body attempts to correct for the low oxygen. Inappropriate absolute polycythemia occurs when ectopic erythropoietin, like an EPO-secreting tumor, causes an increase in red blood cell counts for no physiologic reason. Well, we can predict here that our results will show an increase in RBC mass and EPO levels, with a normal O2 sat. IAP can be seen in patients with renal cell carcinomas, Wilms tumors, hepatocellular carcinomas, and hydronephrosis. Polycythemia vera involves an increase in red blood cell mass that exceeds the increase in plasma volume, resulting in an increased hematocrit. The high RBC mass causes an appropriate downregulation of EPO production. Polycythemia vera is distinct in that it is a primary polycythemia, as opposed to the other types that are secondary polycythemias. These secondary polycythemias occur secondary to some other signal or process. Let's finish up this section with a USMLE style question. A 50-year-old man comes into the physician's office with weight loss, fatigue, night sweats, easy bruising, and nosebleeds. He also complains of pain near his first metatarsophalangeal joint in his left foot. Physical examination is remarkable for hepatosplenomegaly. Laboratory studies show a predominance of WBCs, 50,000 per millimeter cubed, and a full spectrum of myeloid cells in the peripheral blood smear. On genetic analysis, a translocation is found. Which of the following is the mechanism of the first-line treatment for this condition? Alkylates DNA, inhibits tyrosine kinase, inhibits xanthine oxidase, reduces deoxynucleotide production, or regulates and enhances the immune system. The answer here is inhibits tyrosine kinase, and the drug is imatinib. This is a great USMLE style question because it does not give you all the information straight away and requires that you make a few jumps in logic to reach the correct answer. Not all USMLE style questions will be this difficult, but it's a good idea to discuss the difficult ones here so that we can review the steps needed to reach the answer in a difficult question. The first thing to note is that the patient has weight loss, fatigue, night sweats, easy bruising, and nosebleeds. These symptoms, combined with a severe leukocytosis, should make you think of a leukemia of some sort. Next, the patient is 50 years old. That already narrows what leukemias we should be considering. ALL should be in younger patients, and CLL is likely to be in a patient over 60. That leaves us with AML, with a median age of 65. You can't really rule it out at this point. And CML, with the average age of 50 to 60, which is dead on for our age ranges. Also, it is important that the patient is complaining of first MTP pain. First MTP pain should always scream gout when you see it on the exam and when you see it in real life. This reinforces the idea that we're dealing with leukemia and a very fast cellular turnover that eventually is causing a buildup of uric acid. Hepatosplenomegaly and a genetic translocation is just adding fuel to our differential diagnosis fire, as the spleen and liver will swell due to an increase in WC production secondary to some mutation. Now there is an extremely important statement. The STEM states that on peripheral smear there is, quote, a full spectrum of myeloid cells. Now we never really settled on the CML versus AML, even though CML was more likely by age, but here's definitive evidence. In AML, depending on the specific type you have, you will see a large accumulation of parts of the myeloid lineage cells. But in CML, you will have an abundance of all the myeloid lineage cells. So this is a very important clue. Now what we need to do is remember that the Philadelphia chromosome is involved in CML. We know that the Philadelphia chromosome produces the BCR-ABL translocation, and that results in an overexpression of a tyrosine kinase. The treatment for this is imatinib, which is a tyrosine kinase inhibitor. The writer was trying to trick you into adding xanthine oxidase inhibitors, aka allopurinol, in the answer choice because you know that this is used to fight the gout that the patient does have. However, importantly, this is clearly not a cure for the cancer of the patient, which is where the question was going. The other answer choices are methods that can be used to fight leukemias, but are not the first-line treatment in the disease that we have identified. In order, they're talking about the drugs busulfan for answer choice A, hydroxyurea for answer choice D, and interferon alpha for answer choice E. Well, that's going to cover hematology and oncology pathology. We'll be moving on to pharmacology in our next video, and I hope to see you then.